Welcome to the webinar. You have entered as an attendee in listen-only mode.
We'll do that again officially here in just a minute. So Ryan's coming to us from the West Coast, and I'm in Texas, and Guy's on the East Coast. So we got the whole country covered here from one end to the other. Ryan, where are you in Southern Cal?
Thanks, Rich. I'm down in San Juan Capistrano,
Okay.
but our home office is up in Chicago. So, I get the best of both worlds. I get to go back and forth and enjoy a little season here and there, since we don't always get them here in Southern California.
Yeah, for sure. Well, very good. We had a pretty good rainstorm here in San Antonio this afternoon, and lightning, thunder, internet, and the phones went out at the office and all that stuff. So that was exciting for a little while.
That usually happens during our webinars, but glad it didn't yet.
I think we're okay.
Yeah. Well, we're excited. I know a lot of you are probably going to the AADSM meeting in Boston. We're heading out that way Thursday, all three of us, I believe. So come by and say hello to us at booth 310s, where Dental Sleep Solutions and DS3 are. Do you know what your booth number is, Ryan?
Great question. Let me look that up so I can share that with the team.
Okay. Well, we'll stop by and see us. We're looking forward to a great meeting. We've got quite a big group, over 250 people registered tonight. So again, that's one of the reasons we have to mute the microphones, but we will get to all your questions if you just type them in the question box before the night's over.
See if the slides work real quick, Guy. Just click a couple through. And
we did that while you were having your burritos or whatever, but here I will just.
All right, I'm catching up now. Thank you.
Yeah, they were.
Chicken, by the way.
Chicken, that's usually what you have. An iced tea, I'll bet, right?
That's right. You got it right here for me.
Yeah.
Thank you.
All right. Sounds
Well, Guy,
good.
if I could comment with regards to your comment about the AADSM, yeah, we're all looking forward to being there, but the great part about all of what we do, looking at your first slide, when it comes to screen, test, treat, bill, I think we all have a great opportunity to share, with regards to sending people back and forth to our booths to say, hey, these folks are great at this, these folks are great at that. So regardless, folks, whoever's on this call, I think you're talking to some people that you can really dial in with, whichever booth you end up at. I'm sure there'll be some cross-pollination with regards to basically what we're doing and what they're doing and how we collaborate together. But in the meantime, thank God for my team. We'll be at booth number 638. So come by and shake hands. We'd love to see you and at least have some form of face-to-face interaction with you guys.
Well, that sounds great. Well, it's 8 o'clock by my watch, so let's go ahead and get started. What do you think, Rich? And Ryan,
I'm ready. Let's get going. Let's talk about how to do all this stuff. So I'm the bald-headed guy on the right there, and Guy, you got to update that picture, Guy. That's got to be at least 10 years ago, man. That's
But I looked so much better back then. So
yeah,
let's just.
you did look. You looked a little thinner too back then, by the way. But you do look good, and that's us. We're DS3, and Guy and I founded that company quite a few years ago now. So we're 10 years to an overnight success, but we're doing well. We help a lot of dentists do this, and who do we have with us?
Well, we have Ryan Javanbakht with us today, but before we get to the introductions, I want to mention that we're going to be doing this about once a month, maybe a little more often than that, and this is one of our first meetings with a guest. And next month, it'll be on June 27th, same time, 8 p.m. Central, 8 p.m. here in Eastern time zone. And we'll have Douglas Shannon with us. We're going to be talking about CBCT, how you use it in your general practice, in addition to how we use it for airway and TMD. So we hope that you can join us for that. Again, Rich and I have been doing this for a long time. We've done thousands of devices, and this is our mission statement. We're the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine. And our DS3 experience, we just help dentists be successful in dental sleep. We provide the education, coaching, software, everything you need to successfully implement what we call the 4 pillars of dental sleep, which are screening, testing, treating, billing. And today we're going to be talking about 2 of those, the screening and testing. And if you want to learn more about what we can do, anytime tonight you can type in a free consultation, and Jody or Brandy will get with you, and we can show you how we can help you get over a lot of the hurdles in dental sleep. We also do a lot of courses throughout the year, and I'm going to move my little control over here to where I can see better. And the courses are listed here, and we'll show you again them later. We do some 1-day and some 2-day courses, and if you want to come to one of the courses, just type in course, and that'll secure you $50 off a course in the future if it's a 1-day, and actually $200 off if it's a 2-day course. So just type in course, and if you know the city, put the city in there. But if you're not sure of the city, just type in the course, and that'll secure your discount on that. So yes, Rich, we're here to introduce our guest. We're thrilled to have Ryan with us today. Ryan Javanbakht, we've known for quite a long time. I'll let him introduce himself, but I know you've been in sleep and in dental sleep in particular for a long time. So welcome. We're thrilled to have you and talk to us about sleep testing today.
Well, thanks, guys. I really appreciate it. It's an honor, it's a privilege to join a couple of guys like you've been doing this for just a little while, right? So we don't need to talk too much about me, but I can tell you I'm extremely excited to be, one of the co-founders to lead this new opportunity with sleeptest.com. Most of my past has been within either the dental or medical world, so I've been able to see both sides of the story. But really, if you take that dental piece with the vascular world, it is sleep apnea, and that's what we've got to really push and promote, and also I would say build awareness, build a movement around this epidemic, if you will. More important, and that's why I shared a picture of my family. Forget about all the other stuff. More than anything else, I'm a husband to my wife, Selena, and a father to our twins, Micah and Skyla, and that's what gets me out of bed every day every day, you name it.
I get that.
Thank you for having me.
Well, we're glad to have you here. The problem's huge. We're not going to spend a ton of time on this, but Rich, we've been using this slide forever. It's not gotten any better, has it?
No, if you listen to John Rimmers, our great buddy from up north, he says we're actually losing ground today, Guy. We got more people getting this disease than we are diagnosing. So that's the tragedy in our time. How can we be losing ground on something that is as simple as this, and how simple it is to get people screened and sleep tested? But that's why you're all here tonight to talk about.
And it's an awareness problem, and I think the awareness has improved. We don't want to be all gloom and doom that, hey, this is a big problem that we're not solving, because we're moving the needle. I definitely feel the public's awareness. I mean, Rich, you just were interviewed on TV the other day for a local newscast. One of our franchise offices in Tampa is going to be on Friday. Patients know more about this than the dentists are being aware. Physicians are coming along, but we need to do our jobs with this. That was what do you think that did for your local area there for awareness with the news broadcast that they did on you?
Well, I can tell you, Guy, in the 60 minutes after that aired, I had 38 phone calls at my office. And what do the patients all say? Well, how come I don't know about this? How come my doctor never told me about a dental device, And I'm like, well, that's why I do this stuff, But absolutely, that raises the awareness for every patient and every dentist in the entire city of San Antonio in that public viewing area. So, that's the soapbox that we get up on, and we've been practicing this and preaching it for a long time. And, it's great to have people like Ryan getting into this space now to help. We're not the only people out there doing it, although we feel like we are sometimes, Guy. But, that a lot of people are out there to help dentists do this, and we're glad you're on tonight.
Yeah, and Ryan, I suppose you've never heard anybody come and call your services and say, I didn't know I could do the sleep test at home. Is that
Absolutely
a novelty?
Yeah, all the time. And it's taking people right back to, doing this in the comfort of your own bed. And I think you guys nailed it with just the title tonight. It's increasing access to care, because patients are dynamic. They want what they want. They have an expectation and a perception that really takes them to that next level, because you could have Dr. Drake doing this in his community, but then others that are just screening and focusing on their own patients. As long as my belief, as long as you come from the heart, you do what's right, the rest will follow. but you got to have some effective training behind it in order to make that happen.
Right.
So everyone's doing it a different way. Guy, what are you doing specifically in your neck of the woods to really build that awareness or create a movement, if you will?
You know, one thing I've done is educated a lot of dentists, even in my backyard. One of the questions that comes up, oh, well, you know, I've got a guy down the street doing this. So what? I've educated tons of dentists in my area within a mile of my office, and I don't even see them as competition because they raise the awareness of the public. And we have better relationships with our patients. We just have an opportunity to change things. And again, that's not what this is all about, but we're all going to talk about screening and testing. And if you understand, it's really our obligation to start looking at this and our patients, the numbers are so huge that it's not a matter of not having enough. And we're going to be doing more webinars throughout the year, and we'll hit each one of these steps somewhere along the way, most likely, but it doesn't have to take forever. It used to take hours of my time to treat one patient, and now each of these steps, and we'll go through the screening and testing today, you can expect to accomplish start to finish for a patient in under an hour. We say 45 minutes is very reasonable. Rich, I know you probably do it in 30 minutes because you're faster than most, but it just doesn't have to take a ton of dentist time to help the patients. And if you're not doing it, you're losing money. I mean, that's not the reason I hope anybody, not the sole reason you get out of bed in the morning. We hope we want to help our patients and do something right in the world, but at the very least, you're going to lose some, be losing money because it's such a huge opportunity. We'll go through the ROI in a little bit when we get back. So we've been using this slide forever. Would anybody want to comment on what this means?
Yeah, I think you hit the nail on the head there, Guy, when you put this up. So, you know, the more we understand about a problem, the more we understand we might want to fix it. You know, and I think the part of the challenge here with our patients out there is they don't know what they don't know. Right. So, you know, one of the slides you had earlier that we didn't comment on, Guy, was, and people go to the dentist. You know, like 7 out of 10 Americans go to the dentist at least once a year. Now, granted, sometimes it's because they got a hole over here and they put pus draining out or something like that. But as dentists, we're in a great opportunity. We have a great opportunity to start to educate these people, ask questions. That's what we're talking about today, you know. So, you know, don't just jump right to the answer. You know, I don't want to wear CPAP. Well, you don't have to, you know. Let's talk about how to get you tested first, or let's just see if there's a problem there. And I love this Simon Sinek stuff. You know, you start with the why, and then you work out. You know, what do you do for a living? You know, well, I save people's lives. Well, how do you do that? You know, well, we put a little piece of plastic in their mouth and it helps them breathe better, and they sleep better, and they don't have heart attacks and strokes. You know, that kind of thing. So, and we all have that. It doesn't have to be this long, drawn-out conversation with our patients, but we're in such a great position to be able to catch a lot of this stuff in our patients.
Yeah, and I think, Ryan, you've got a pretty good why story, don't you?
Yeah, do you mind if I comment on that last slide, though? I don't mean to make you go back, but just really,
no problem. There you go.
I love this slide, especially the part that says, holy, you know what?
Yeah.
The question becomes, guys, is it awareness? Is it education? Is it a movement? How do we do it effectively to the point where the patient physically owns their condition? Because we're throwing a lot of numbers at them. We're throwing a lot of stats at them. But how do you get the patient to own their condition? Because otherwise, this whole graph that you see changes dramatically once they own their condition, and you pay close attention to what those key points are that really even matter to them. So I just want to make that point on the slide, because I do love this slide, but awareness of the problem, but awareness perhaps is the problem.
I'll quote one of my mentors, Pete Dawson. He said to me years ago, you know, Guy, if you just keep in mind every reasonable person wants a healthy mouth, you know, they just don't know what that is. You've got to help them discover that. No one wants decay and abfractions and periodontal disease. Well, I think that's like true times 10 to this. No reasonable person wants to have heart disease, heart attacks, strokes, diabetes, poor sleep, you know, all the things that go along with this, which we'll have a slide for. So absolutely, they just have to discover it. And I think it's one of the reasons it's easier really to get behind this in your practice, because it's really easy to be passionate, especially when we can share some of the why stories. Why are we passionate about it? Ryan, you may want to comment on the slide too, and I know you have a pretty good story I'd like to hear.
Well, I'm happy to comment on the slide. Yeah, Rich, you said it perfect though, right? For most people who have seen me speak, I like to speak from a place of, start with why, start with your purpose, and then you can move into everything else. But, from a business consultant, business coaching perspective, when you're looking at these things, everybody knows what you do. They have a pretty good idea of how you do it. But if you can physically get not only yourself as the dentist, the doctor, clinician, whoever, to have that story and share your why, but then also have your team share the why, get them tested, get them treated, anything you can do to have that entire team on board to share that why, that's what resonates with people in the chair. I'm a patient too, so I want to hear that.
Absolutely. So, okay, there was the slides for that. Sorry, I didn't keep up with your slides. That's on okay. That. I was thinking the next slide was your particular why story, which I found pretty fascinating.
Yeah, and guys, this is what everybody should have. And again, if you've seen me speak, I drop this in a little bit everywhere I go. This is my dad. He's one of the 85% of however many, call it 30 million, 40 million people that suffer with OSA. Start through the timeline, 10, 15 years ago, open heart surgery, quadruple bypass, 4 stents placed. Guys, I used to sell stents in the OR and help physicians put them in. They're only good for 7 years. He's had some that are in there for 10. Okay, multiple angioplasties. I've been in those cases. And if he would have simply been evaluated for sleep in one of your practices, he'd be in a different position today, because he actually needs back surgery. They're afraid to open him up because they don't think he'll make it through. So now he's in severe pain because this was never diagnosed and addressed a long time ago. So this is why I love sleep medicine.
It's important. I go to the gym a fair amount. I try to anyway. And I was introduced to the fire chief there years ago. A friend of mine introduced me to him, and I see him in the gym. He'd say, "Hey, doc, hey, chief," past each other. And one day he asked me, he said, "Hey, I can't wear my CPAP. I heard you, help people with some sort of dental device. Can I see you?" I said, "Sure. Let me give you a card." I didn't have any on me. Next time I saw him, I put some cards in my gym bag, and I handed him the cards. Just come in, we'll give you a free consultation. The guy's in his 50s, fairly healthy as far as I could tell. And within a week, he was dead. True story. You just think how that, it just affected me. Like, here's this guy, he apparently had surgery. This is right out of the paper. He'd probably had UPPP surgery, it sounds like. And no one had mentioned to him about a dental device. The only reason he knew there was a possibility of that was because of a sign I had on my car about it. And, again, it's that awareness. And had he been aware, who knows? We don't know, but, where he would be. But right out of the paper, they felt that his apnea had a lot to do with him dying in his sleep. And my other why is I've been snoring since I can remember. I've been wearing a dental device, and I tested myself years ago, and I wear a dental device every night. I don't wear this thing. I wear a dental device, and my wife is very happy that I do. I feel rested, and I feel, I wouldn't be as healthy as I am without it. And I know Rich has stories we could go on about camping and fishing, but we probably ought to move on a little bit about it. Unless, Rich, you want to touch on yours briefly?
Mine's not near as moving as either of you guys. I just got tired of doing dentistry, man. I wanted to do something different. So, and this is easy, but I get to experience that kind of stuff every day. Right. We do that every single day. So yeah, you bet.
And you just touched on it's perfect segue into this is dental sleep. It's complex in some ways. There's a lot of moving parts, but it is one of the quickest things to learn how to do. If you're going to learn to do something new, you have to go through what I call these 4 stages of learning. And the first one is when maybe you made your first mandibular advancement device and thought it was just simple enough. You just throw it at the person and they quit snoring, and that's all there is to it. That was me 17 years ago. And I was in the first stage, which is when you're unaware and incompetent, or we call that unconscious incompetent. You're too dumb to know that you're not doing a good job. Then I realized that there's a little more to it. We had to have follow-up. There was some TMD parts. There was some things like that I needed to learn. And so I had to do some effort here to get some systems in place to where I could do this while I thought about it, and I was aware I was doing a good job, and I was confident because I had good systems. So I had to develop systems and come up with skills to do this. And then once you get over this hump, it becomes second nature, and that's where you want to be. You want to get down to where it's unconscious competent, to where it's just like driving your car. And I think the point of this slide, which is a segue from what Rich said, is dental sleep is really enjoyable. It's lots of fun. You help lots of people. And this curve, because of systems like DS3, because of sleep testing like sleeptest.com, it makes this learning curve so much easier than what we went through 17 years ago. So I guess I touched on that well enough. Everybody still there?
Keep going.
Yeah. All right. Well, you know, Ryan, I know you know what this was kind of about. I think one of the questions that come up is, well, yeah, is a home sleep test as good as a PSG? And, you know, I think we're going to talk about that in a few minutes. But, you know, really who makes those decisions for the most part these days?
Absolutely.
The test, and sometimes is dictated by the insurance. This slide just shows that an insurance company in Michigan made a decision, hey, we're not going to do lab tests anymore. And as a result, a lot of sleep labs in that area went out of business, and the number of tests in just a matter of months that went from lab to home tests increased to the home test. And that was really the decision that was not made by the patient, not made by the healthcare providers. It was made by the insurance company. So, you know, you have to understand that we're going to talk about PSGs and home sleep tests and the pros and cons, but insurance companies are very much gravitating towards the home sleep test model these days.
Well, if you'd like, I can jump in here, Guy.
Perfect.
And talk about whether you can or whether you can't. And, you know, being in the sleep space, guys, I'll be the first one to tell you, even as a home sleep test provider, I'm a big advocate of, just like what you guys do, multidisciplinary approach, right? However, that being said, in a perfect world, a dentist, any dentist would have a sleep physician across the street who is oral appliance friendly and is tied directly to a sleep lab. In a perfect world, right? That doesn't happen every day. So now we've been given the opportunity. I heard you say, Guy, I don't know if you notice, I'm taking notes as you guys are talking, but I keep hearing the word help. And I heard you say the obligation. It's our obligation, from my perspective, for me to build awareness, but it's perhaps, I don't want to say it's the wrong way, but your obligation in the dental sleep space or dental space to do your homework, know what you can do, dive into this, do it the right way, and continue to lead with purpose so you are changing or saving lives, or maybe the ones we missed.
Right.
And you know, whatever we do to create an opportunity for access to care, that's what we've got to do. So in most states, yes, a dentist can order a home sleep test, but I will tell you right now, do your homework. Just like we want the patients to own their condition, it's incredibly important that the dentist who jumps into the space, who doesn't have 17 years like these gentlemen, does their homework and doesn't necessarily listen to opinions of one or another study club that they went to. Do it for yourself so you can feel comfortable. You can personally sleep well at night.
Absolutely. All right, we're going to talk briefly just about some definitions. I think some of this may be remedial for some of you, but some may not. So we'll hit it pretty quickly. But if we're going to be talking about sleep testing, what are we testing for? What are we measuring, in other words? And what we're measuring is whether the patient's breathing at night or not. So we're going to start with the A, which is apnea. That means you quit breathing for a period of 10 seconds or longer. So Ryan, this looks pretty typical to some of the signal you might get from a nasal cannula. Would you say each one of those is a pretty decent breath?
Absolutely. I like
yeah.
that.
So each one of those is
absolutely,
long, nice breathing. And what happens with an apnea is we use the word flatline sometimes. You know, if you're going along, you're breathing and you quit breathing, and intentionally use that word because it is serious. I don't think we're overusing the word flatline. I think it's exactly what happens in an apnea. For 10 seconds or longer, the patient just quits breathing. And it's probably not that they're holding their breath either. It's probably that they let a fair amount of the breath out of their airway before they quit breathing, because that's what could help contribute to the collapse. Anything I missed on that, Ryan, you'd like to comment on?
No, absolutely. You got
Okay.
it. You got it right on the money.
And then H, H stands for hypopnea. I think of this as like a hypopnea, so it's kind of less than an apnea. And we do the same thing. We measure the airflow, and the airflow starts to reduce. It becomes less. And at the same time, the pulse oximetry drops on that patient. In this case, for the Medicare guidelines, 4% desaturation. So you're breathing, and then we have a less breathing. That is what we call hypopnea. Hypopnea, some people say. I guess if you're from different places than Kentucky or Texas, like I grew up and Rich is from, but it's a decrease in breathing. So this
those are both accompanied, with desaturations. You know what I tell people, Guy, I use the analogy of 10 straws. I say,
Yes.
look, you got 10 straws in your mouth and you're breathing normal. That's great. If I take 5 away, or 6 away, now that's like a hypopnea. And if I take them all away, that's like an apnea.
Right.
And people seem to get that. And then we add them all up and we index them per hour that you are asleep. And we get this number called an AHI. It's like a tuna. No, it's the AHI, and it stands for apnea hypopnea index. And there are just a few acronyms that we throw around in sleep medicine. And again, like Guy said, this may be remedial to some of you, but we teach this to a lot of dentists, and we'll say this 100 times, and the next day we ask them, what does AHI stand for? And we can't always remember. So this is one of those that you got to take away with you, the AHI. How many times you quit breathing indexed per hour.
Absolutely. And then we take that, and Ryan, is this the guidelines your doctors typically go by? What would they consider normal? I'll let you go through this if you don't mind.
Yeah, I'm just waiting for it to come up. There we go. Yeah, so this is the typical standard that we're all working with in the current space. This is what the medical community sees as far as what's considered normal to severe. So 5 events, let's call it 4 or less, normal. Okay, mild is gonna be 5 to 15, moderate 15 to 30, severe 30 or higher, or 31 or higher, however you want to look at it. Rich, you brought up a great point the other day. We won't get too far into it, but there's a lot of other things that you and I and everybody else are thinking as far as what really comes into play. And this right now is truly sort of the guideline, if you will, on what our physicians are looking at and how they're going to score that patient mild to moderate for that to be in your sweet spot versus severe. And as I'm sure you guys typically recognize, gold standard would be to refer out for PSG or PAP therapy, et cetera. But this is the guideline we're looking at. My frustration comes into play where we have a UARS patient, upper airway resistance syndrome. And some of these patients absolutely need help, but because of what medical payers will say or contribute their feedback on, they might be considered normal even though they've got an RDI that's at 20 and their AHI is at 3. So again, this is what we're using for now. I think you guys and many other people would love to see some things change in the future, but this is a great guideline. What do you guys think?
Yeah, we don't want to confuse people either, Ryan. So there are a lot of acronyms out there. You think about this as a continuum, guys. I snore a little bit, I snore really loud, then my airway starts to close down, and we get into what Ryan said was upper airway resistance syndrome. And then we get into, hypopneas and apneas. So just think about this as being a continuum. And just because an insurance company says, hey, they only have an AHI of 4, you shouldn't treat them. That's not necessarily true. We know that people can be very sleepy, they can be tired, they can have a history of coronary artery events, cardiac events, they can be pre-diabetic, and they have a sleep test and their AHI is 4. So you got to keep this in perspective. People that are sleepy and tired need to be treated. And right now, these are the guidelines that we go by. I've always thought it was kind of funny, Ryan, that somebody can have 4 events an hour where they're not breathing, and that's normal. I didn't come up
trying to be politically correct, guys.
Yeah, I didn't. Guy and I didn't come up with this either. But here are the guidelines. This is what we go by.
Yeah, and I guess I should mention that a lot of this has to do with insurance paying. Mild to moderate apneic patients, typically insurance will be covered for dental devices as first line of therapy. Most of the time, they may have to have some comorbidities if they're mild. And then severe, the standard is more or less that we should refer them for CPAP for that first, especially if we want insurance to cover them. Now, if they can't wear their CPAP, then a dental device might be a very good treatment alternative. So that's where those numbers really come into play is who's going to pay for this. So, you know, can we just send these people to you and, or can we just diagnose this ourselves? How does this work? All right.
Well, it's a good question. I appreciate you bringing it to my attention. Let's just call it what it is. Up front, the key piece here to number one, I always like to think of the patient first, me as the dentist or you as the dentist second, and then everything else that follows. And first and foremost, we want to do what's best for the patient, number one. How you obtain that diagnosis, it is completely up to you. There are a couple different pathways we'll talk about tonight. Yes, of course, you could do that through ds3indosleeptest.com. But at the same time, that's the one thing you want to do what's best for the patient, but also do what's best for you and your practice and how you're treating patients. So really twofold. And then often it might come along with, so I may have a diagnosis, typically get through with a recommendation. Every so often, an insurance payer might request for an actual RX for oral appliance therapy. But the key here is that we can't technically diagnose. Use a local physician, use a home sleep test, use a PSG. There's plenty of models like you see here on the slide to help do that for you, to really lead the way through the rest of the pathway, if you will.
Right. Yeah, we're going to get to each of these multiple pathways to these three pathways to obtaining a home sleep test in just a moment. And by the way, we're almost halfway through. Keep typing your questions in if you have them. We're answering them as we go. We'll stay on to answer any additional ones that you may have. So, and if you need to be unmuted at the end to ask a verbal question, we can even do that. So hang in there. We got a lot of people on here tonight, and we'll also put up those slides at the end there as well. If you want to have a free consultation with the DS3, one of our trainers, to see how we can help you in your practice, just type in consult and they'll give you a free consult, and type in course. We'll put those courses back up again for those of you that missed it, and you can get $50 off of 1 day and $200 off of a 2-day. And we'll mention our booth numbers too for the AADSM right now in the middle. 310 at the AADSM. What was yours again, Ryan? And we'll mention again.
638.
Yeah,
638.
638 and 310. Come by and see us while we're there too. So there's your little break in the middle to update you on where we are. So I really like this slide, Ryan. This is yours, and so I'll let you kind of walk us through it as well, if you don't mind.
Well, I'll tell you what, I don't have all the answers, but I like to ask a lot of questions from smart guys like you and other people I've heard speak. And really what it comes down to, guys, is going back to those previous slides, that a dentist cannot diagnose apnea. Okay, but on top of that, we've got to think about the fact, as you look at these slides in the circle, maintain the multidisciplinary approach however you want to do it. Because if you think about it this way, you are now treating a medical condition that really has no cure, and we're billing their medical insurance for this uncurable thing that is technically linked to heart disease, diabetes, stroke, obesity. The numbers and the names go on and on. So great feedback that I've learned from a key opinion leader in the space. I won't name his name because I don't know if he's on or not, but share this responsibility of the comorbidities. If you have a patient that has a diagnosis of apnea, 5, 15, 30, 65, whatever that looks like, share that with the local physician, whether it be their PCP because you don't have the referral source to a local sleep physician, ENT, pulmonologist. Get them back simply to have if they haven't in 1 year, if they have not had a physical done, but you have a diagnosis of apnea, do something with that and take care of their overall health and wellness.
Absolutely. We're not doing this by ourselves by any stretch of the imagination. So
it's a team approach, right?
It is. It's absolutely. And we shouldn't even desire that. I mean, we're a piece of the puzzle. We're not a solution. I liked what you said. We're not curing sleep apnea. We are a solution to help their apnea, and we need the other the healthcare providers to be on the same page with us. It's a team approach, absolutely, all day long. So, and we're not all just about home sleep tests. I mean, I think we see a big value in home sleep tests, but PSGs and HSTs, there's a diverging path you have here. I'll go to the next slide there. I'll let Ryan, if you want to comment on this one as well.
Yeah, I think you nailed it too. It's this, like your oral appliances, guys, it's not one size fits all. So one patient may do really well in an Arval, one patient may do well in a Noventis, Lambert, whatever that looks like. But the reason you go about those different ways is because every patient is dynamic, every treatment is dynamic. The whole goal here is to minimize barriers to treatment and testing and increase that access to care, because what we're trying to do at sleeptest.com, or hopefully in the rest of the industry, whether that be in Boston or not, is really push for this motto, philosophy, whatever you want to call it, of no patient left behind. That means it doesn't matter how they get tested, Guy, Rich, it doesn't matter which appliance you refer for, right? It's let's get them help. So we're big advocates for anything as long as it's helping the patient.
And you know what? It'll all come back in spades too. With you know, we refer people out for CPAP, we refer people for PSGs, and you know, if we're helping the patient, it'll help your practice, it'll help your life. It's all positive. I like this saying because I actually wrote this a long time ago in an article that I got a lot of grief over, and there's a big debate, you know, at times is, you know, which is more accurate? Is a PSG more accurate or a home sleep test more accurate? And when I teach courses on this, Ryan, I usually ask that question. I get them to raise their hands, and you know, and no one really asks the question about what do you mean by accurate? I mean, let's define accurate. It's really the question that you have to say here, you know, and so I kind of trick them. So if you ever hear me speak, you know, you won't fall for that one. But you know, a PSG is a more accurate study. We measure more things of a less accurate night's sleep, but also a home sleep test may be a less accurate study, but of a more typical night's sleep. And so which is more important here? We want good data. We want a good night's sleep. I guess they're both important. And what happens, Ryan? Do you have people who've had PSGs and they say, God, I just couldn't fall asleep during that test, and then you test them later on a home sleep test? What do you find out about their apnea oftentimes? Do you see that maybe it's
so this is the toughest slide. Yeah, well, you know, it could go both ways, because it will depend on, you know, most of these people, as you know, Guy and Rich, it's most of these people who don't sleep well as it is because of either apnea or insomnia. They have severe anxiety about even going to sleep. So where would that patient do best as far as where we're getting those results? And when you talk about accuracy, but then you might have someone who has no problem because they're exhausted, they'll pass out on the spot. That patient might do better or well in a PSG overnight. But what we're finding, again, it goes back to access to care and being dynamic in the options that you can give a patient. And that's where home sleep testing really does come into play with, I mean, the devices now are so small, you guys know, it's very simple. Yeah, very easy to do.
You're trying to be politically correct, and I appreciate that. But, you know, my bias is for home sleep tests. For number one, more people are going to get them. The other thing is, if we don't sleep well because you're all hooked up in the sleep lab and you're going to bed at 9 o'clock instead of midnight like you normally do, and you know your different pillows, all that kind of stuff. If you don't sleep well, what we have to realize is that we will underestimate the apnea. I mean, if we don't get to the deeper parts of sleep, you won't have the apnea, and so that is a factor for both tests. But even more of a factor if you're spending a night in an unfamiliar place with people spying on you in the other room and in a bed that's not your own. You know, I can say at the very least there's pros and cons, and we can't just say one's more accurate than the other. There are, like I say, people in the other room watching you. You know what? We don't have to spend a ton of time on this, but the difference in a PSG really is you measure more of the brain waves. We measure sleep staging. We measure some muscle movements. So the things on the left side of your screen are typically more PSG, and the things on the right side are more HST, so PSG has both. And if we're just trying to see if someone breathing at night, and we're trying to see if they're trying to breathe at night, we have the effort belts and the airflow and the pulse oximetry. I don't know that, for a lot of cases that we need to have sleep staging if we're just looking for an airway problem, is my take on it. Richard or Ryan, do you want to have more comments on this before I move on?
Yeah, I'm sure if I was a board certified sleep MD, I would disagree, because we start there and we like data. That's one of the things as doctors we like this data.
Right.
And right now, I think, Ryan, what you said was access to care.
Right.
Man, you hit the nail on the head there. I'd rather see 100,000 people this month do a home sleep test than 5,000 people do a PSG. It simply is, it's the bottom line is most of the time it's good enough. And that right now, that's good enough for me, so, we want to get people tested. We want to get them tested, and you got all kinds of data here. What does all this stuff mean, Ryan?
Well, let me just say this before I go there. I love that you guys can be a little less politically correct, or however you want to put it in your space. It makes my job a lot easier to share the stage with you because you can do that. It does. It's access to care, no patient left behind. Everybody wins because more people get tested. Now, when I'm looking at this data, and part of the reason I put this slide in here, you go to show this data as a result from a PSG, polysomnogram. And then you look at the raw data that we get from a home sleep test, whether that's any of them. We're pulling the same raw data. It really depends on how it's utilized, right? Is it an algorithm? Is it a sleep tech? I have no disrespect, they're phenomenal. But is this a true physician that's looking at this data and able to pull apart those hypopneas that might mean something else, because the report might say from the quote unquote algorithm that this patient has central apnea, where really is when one of our sleep physicians can look at it and go, nope, it wasn't necessarily central apnea, but we're seeing multiple hypopneas in a certain scenario that caused X, Y, and Z. But again, the goal here in this slide, and the one you're going to see in a few more, is physically you can get a lot of the same data here. How we get the data is what's most important, like you were just saying.
Yeah, I mean, it's there's no perfect test. I mean, until they can invent some sort of a laser that mounts in the corner of your room and doesn't touch you, anytime you strap something on, it's going to affect the way you sleep. But there's certainly less and more invasive ways of doing that. So, there's a lot of different instruments out there that can do this. We want one that is less invasive, that is not as cumbersome to put on, but still gets the data we need. Is this the unit you use for a lot of your tests, Ryan?
We do. We're using the ResMed Apnea Link Air, guys, and the next slide will show more in just a few. But as we stay here, the one thing you want to look for in a home sleep test, and I can say this from experience in the last several months, even this whole year, the fact that we haven't had one sleep test have to go back out to the patient because of ease of use. So I've got to think of the patient first, myself second, patient, dental, sleeptest.com. That's how it should go in the hierarchy. So if the patient is comfortable, they can do this. That means we're going to get, like you said, Guy, accurate data. And then you have happy patients who aren't having to be retested and another device sent out. Now what's going to happen next? So if anybody's looking for a sleep test device or a sleep service, really just look into the device that either try it out, experience it for yourself. And we do that. We have all the dentists that come on board with us, no cost for the dentist. We want you to feel this and experience it. And then we do a friends and family discount as well.
Oh, great.
Learn the product, experience it, but then also be able to find a story that you can share, like what you guys said, build awareness, right?
Absolutely.
I like that. I didn't know you guys did that, Ryan. That's nice because, when we do 2-day course, I used to be the guinea pig all the time. I'd go, okay, who gets to do the home sleep test? It was me. So I probably had 20 or 30 of these home sleep tests. So, and I think it's important as a dentist to do that because you realize how simple it is, and people have this kind of fear like, oh, I'm going to, you know, I don't know, maybe you just hear the word test and it takes you back to high school or something, you know, I don't know. But you know, if take Ryan up on that, you guys. Man, it's because you get to really experience it and you see how simple it is. And now you can relay that to your patients. Hey, it's no big deal.
Yeah. And this is some of the reports that you get here. Tell us about this.
Yeah, and we'll get to more of this down the road, guys. But this is one of many home sleep tests that the report that will spit out. It's just a matter of how you get it and what comes along with it. So we'll talk more about that in a little bit. But easy to read. You just want to make sure, again, that you've got physicians touching and feeling and manipulating or feeling the data itself, as opposed to just something being spat out. Very important with regards to what you choose as far as the 3 different models, 3 different pathways you go down.
I might have skipped a slide there. I apologize. There we go. That's what you said. Yes. We're looking for the AHI, and we need to have physicians to assess it. Sorry, I got a little trigger happy on the slides there. So the 3 pathways.
Should we let Rich take over?
I don't think I'd have to. I have the PowerPoint on my computer, so we'll have to.
We'd already be through if it was up to me. I'm fast on the trigger, so.
The 3 paths. I like the way you did this. This is, I mean, it's real concise, and you know, if we're going to use a home sleep test, then there's really three ways that we can utilize those. And you know, this is what you do. So why don't you walk us through these paths, Ryan?
Yeah, absolutely. This is number 1 pathway. I believe you guys heard me say this before. Collaborate with a local physician. Work with the sleep lab across the street. To date, that is incredibly beneficial for you, not only to grow in your dental sleep medicine experience, but to give the overall health and wellness and really care that the patient deserves. You know, again, great opportunity if you have that, and if they are oral appliance friendly. It's just hard to find in today's world. Especially with the decreasing amount of physicians that are coming out and actually going towards that sleep fellowship, we don't have clearly enough physicians to be able to work with across the street or across the state for that matter. But again, great opportunity. You can find that, get out there and pound the pavement and find it.
Yeah, sometimes starting with screening your own patients, you know, you'll talk to their primary cares, and you'll find these people as you go sometimes. And you know, we've already talked about this a bit, but man, nothing on that list looks like a lot of fun to me. So sleep apnea is not good for you. I see the bottom one there, gout. I just talked to one of my best friends from high school, and he's got apnea and just recently started treating it, and he has gout, he was telling me. So I said, you know, it's all part of this inflammatory response. You know, none of these things we want. So getting that airway open is vitally important. These are some of the units you can buy, Ryan, if we wanted to go purchase one as pathway 2. Right.
So this is pathway number 2. If you're looking at that horizon, a lot of devices out there, guys. I'm not going to sit here and go through each one. I'd be more than happy to have that conversation. Again, this goes back to looking at your state board and what you can do versus what you can't do. Is this for diagnostics? Is this for titration? Are you just trying to get a read to determine where the mandible is at a certain time and place before you do your final efficacy? These are all great devices. In a perfect world, if I could take 3 of them together, I'd have the perfect device. Yeah. So again, look into it and trial these before you go out and buy one. I'll tell you, my wife has seen every sleep test in the world now in the last couple months as far as me being tested. So do your homework, but a lot of great pieces on this slide here.
Yeah, and if you're going to buy one, I'll talk about this because, and Rich may have a comment as well on it, because I put this together. But, you know, some of them cost a ton of money every time you use them. They cost $60, $75 just to give it to a patient, not including having a physician to interpret them and so forth. So being able to do multi-nights, costing a reasonable amount each time you use it. Of course, we want to measure all the right channels, the air, the nasal airflow, pulse oximetry it has to have, ideally having some respiratory effort. And obviously, let's make this really, really clear. You cannot, as a dentist, buy one of these and hand it to your patient and hit the little button and it says what the AHI was and say, oh, you have apnea. You cannot do that. You need to take this information, this raw data. A sleep physician needs to look at it. Ideally, a technologist needs to look at it prior to the physician looking at it, and to manually look at this information, and then they're the ones that can look at this. Anything that I'm missing when I say that? I think it's real. We don't want anybody to get off this webinar and think that you can go buy one of these and you as a dentist make a diagnosis for apnea.
Can you, Guy, if you can't say, you have apnea, can you say you might want to go get some more life insurance before I send this to the physician?
You might, and I know some people do use them for that way, more screening devices. But these things you can buy them, and most of them have companies that will interpret the test that they can hook you up with, and that have physicians that are board certified in your state. And I used to do this a lot prior to having great companies like sleeptest.com out there to refer them to. But I had to buy the equipment, I had to send it off the physician, I had to pay the physician for the interpretation, I had to bill the patient. And even though I probably have 7 or 8 of these in my office, I rarely use any of them because I'd rather send them to sleep test and let them do this. The patient seems more comfortable with that because they're kind of used to that. They go in, the physician says they need blood work. Well, they go to the lab to get the blood work. Same thing here. We're referring them. Of all the things here, Pathway 3, I think makes a lot of sense for many of the cases.
Yeah, and I will say the logistics of keeping track of all of these things becomes a nightmare.
Yeah.
At one point in my office, I had 20 of these things. And I think 1 week we lost 3 in 1 week. Nobody could figure out where they were. So, the Pathway 1, the Pathway 2, and like you said, Guy, if you have your own machine, we can help teach you how to use it. Like Ryan said, you can still collaborate with physicians. There's a lot of ways to do this, but the path of least resistance for all of us, both dentists and patients out there, is to let sleeptest.com do it.
Yeah, and I think we're going to walk through the old way and new way, and due to time, I'm just going to go right to that slide. I mean, Rich and I teach this a little differently, but I really like Ryan's slide on this. This is how we used to do this. Ryan, I'll put up the images and I'll put the percentages. You want to walk us down that path there before I put the numbers in?
Me out with it. Evolving. This is what has been evolving in this space. And the old model, or what has become of the previous model, was I fax off my script. Hopefully it hits the PCP within the week. I don't know, but I don't know where they are. This is now in La La Land or space. Yeah. If they make it to the sleep lab, and Guy, you can click through so you can see the percentages here too. These are guesstimates, but if you imagine you send 100% of your faxes off to that PCP. Now, of those, maybe 70% actually make them there, guesstimate. Now, maybe 30% end up at the sleep physician. Now I'm going to a PSG. And I've got 10% maybe that make it that far. And then what happens is you see that patient 6 months later in hygiene, and they either never made it to the sleep lab, and if they did, they were prescribed some form of therapy that you couldn't provide. So if you go straight to the next slide, Guy, and I'll let you comment on this, but this is what ties it all together on the next slide here, is how many patients actually got this opportunity to walk back into Dr. Drake's office after they went from the fax to the PCP to the sleep doctor, the sleep lab, and was the physician even interested in having this conversation with Dr. Drake about oral appliance therapy? Did he believe about it? Anything about it? So our whole main focus in this space, when you talk about access to care, about testing, give the dentist the control, because the oral cavity is your world.
Right.
So if you maintain the control of the patient all the way through the process, you can do what's best for them. And of course, in our space, in the dental space, we are still referring for CPAP, APAP, PAP therapy, because we believe in it for severe patients, or where it makes most sense. I think that's where we need to stand. But again, it's how many patients have this opportunity in your office?
Absolutely. That looks a little easier going home and then getting a dental device versus going to a sleep lab and getting a CPAP. And I'm not saying that that's not the right for some cases, but I think the key thing that you're saying there is what Rich and I have been preaching for a long time, that that old model, PSG CPAP, results in a lot of patients not getting care. And we need to step in and help the patients with other alternatives. And for the people that CPAP help, back to my buddy I was talking to last night, he likes his CPAP. He's been wearing it for a little while now. And, you know, so that's a perfect solution for him. But if it was a perfect solution for everyone, we wouldn't be on this webinar right now. That we need other solutions to PSGs. We need the home sleep test solution, and we need solutions to treatment alternatives, the dental devices. So tell us about Path 3 and how we would work with sleeptest.com.
Absolutely, I'm happy to. Thank you, and I'll speed up just a little bit so we're considerate about the folks on the other end who need to get to dinner and take care of their families. So the third opportunity, guys, is looking for a third-party vendor to do all this work for you. Allows the patient, but just like Dr. Drake just said, the recovery of these things, the scheduling of these patients, all of the above, the operations and logistics behind the scenes is a huge pain in the backside. So having someone to be able to do that for you and then get results to you in 3 to 5 business days with a diagnosis and recommendation from a board certified sleep physician is going to allow you to what it says here, do what you do best and refer out the rest. Not intending to rhyme here, but that's the case. I'll let you go ahead and move on to the next slide and we'll show them exactly how it works.
The next one here, there we go. Simplified.
Yeah, next one's great. Yes, so the simplified process, guys, going back to what we do at sleeptest.com, and that's okay, you can go right ahead, Guy.
Okay.
Really awesome opportunity to partner with S3. There you go. And you can go here too, either way. So just don't go past the last picture there.
Right there.
The long story. There we go. So this does everything for you guys. The first step is treating the patient in your practice, doing that effectively. Okay, after that, you can submit everything through the DS3 software by clicking a simple button. We do a complete verification of benefits in less than 48 hours. Typically, it's done in the same day. Again, expeditious is one of our core values. Reliable is one of our core values. It's important that we get this stuff done for you guys. The home sleep test goes straight to the patient's home. So again, going back to what Dr. Drake said, you don't touch these things, you don't see them, you don't have to operate them, and you don't have to pay for the disposables as well, like you said, for a 2-night study. They do a 2-night study at home, everything comes right back to us, and at that point, within 3 to 5 business days, you've got a diagnosis with a recommendation from a board certified sleep physician that gives you the opportunity to take the next step with that patient. So again, simplified process, easy through DS3.
Yeah, and if you're a DS3 member, and we'll talk a little bit more in just a few moments, we'll be finished close to on time, maybe a couple minutes over, and we're going to get to all your questions. But we have one of our proprietary products is a screener. You have a tablet, you hand it to your patients, they fill out a Epworth, which is a questionnaire about sleepiness. They just tap the buttons. It takes about a minute per page on this to fill out. They have some other sleep questions about snoring and jerking of the legs and bruxism and things like that that are on the questions. They just hit yes or no. And then they have some comorbidities that they can go through. And again, it takes about anywhere from 2 to 4 minutes to fill this out. And then your patient's going to see something that looks like this. Oh, you have severe risk. And, you know, part of what we teach at DS3, and we can go over with you if you want a free consultation, just type in consult. We can go through the verbal skills on how you discuss this with your patients. But man, you get this in your hand on this tablet and the patient realizes, back to the slide we went over at the beginning, that I'm at risk for heart attack, stroke, gout, poor sleep, you know, just a lower life expectancy. Wow, what can I do? Well, you can just click the little button right here, and you can order a sleep test from sleeptest.com, or if you're on the main patients chart, you can click right there, and it's going to send that information to sleeptest.com. And that's kind of slick. But the slick thing really is that I like the most about it is when it comes back, it's all uploaded. I have a slide coming up in a few moments that shows that all the AHIs laid out nicely for you. You all scan a copy and put it right in DS3. So, man, I personally really love working with you all on sleeptest.com and DS3 together. It makes this a really efficient situation, and it's not costing the patients much. It doesn't look like. I mean, is this $250 on the high end? Is that that's what I've been telling my patients? Is that correct?
That's correct, Guy. And so what we've done, guys, made it simple. You know, one price across the board, whether you're medical PPO patient with coverage or not. You know, a lot of other folks have these tiered pricing, but what we found in our experience in our market research is that if you give a front office two different numbers to play with and they're looking at a medical insurance card and they're thinking, is this EPO? Is this PPO? Is this HMO? I don't know what it is. So with giving the staff, the team, an easy number to think, okay, as they walk out the door, physically educate that patient on what's next using our patient guide, et cetera, but also letting them know it should be $250 or less. And real simple to take that right over the phone or bill medical insurance. Very straightforward.
Absolutely. So the patient gets a call from you all. They because all that information is transmitted through DS3 if they're a DS3 member. You mail them out this ResMed unit. They are tested. They mail it back. You handle having the physicians read it, and I think the next slide shows the actual test results that come back. Is this what people can expect to get back from you all, whether you are or aren't a DS3 member? You're going to get a copy of this?
Yeah, so I think you nailed it too, Guy, and it's coming up in the next slide or two. But yes, you would get a copy. What we do different than everybody else, we do give you both copies, one of each night, but then we give it to you along with the board-certified sleep physician's information. The great thing about this, guys, not only is it instant communication to our team in customer service to move forward right away from your DS3 software, sleeptest.com will also go to the back office of your DS3 software and implement this system and information right there in the software. So if you go to the next slide, Guy, they'll actually show exactly what that looks like. And I think this is what you were saying is your favorite part. It's less work on behalf of your team,
Absolutely.
less work on behalf of the doctor, and it puts it in our hands as far as the logistics and the operations go.
Yeah, and if you want to see the actual reports, you just hit the view button here, and you all have scanned a copy of that, so it's all digital. And it just lays it out nicely. At a glance, you can see some of the key information in that test. And of course, you can read the entire test if you want. So this saves, my team loves it because it saves them time. My patients like it because, look, we're just saying, hey, you have a concern here. We need to get you tested. Let me, you're going to be getting a call from sleeptest.com to go over in the logistics of shipping. And we're going to see you back here in about 3 weeks to go over these results. I mean, it's just that simple. I mean, compared to, like Rich said, going to 14 different devices and programming them, handing them, or trying to work with a physician, which works well if you find the right physician in your area. But we already, went through the challenges on that. So we're really enjoying working with sleeptest.com. Again, we're going to be at the AADSM, and I know you are too. We're in booth 310, and please come by and see us. And you are in booth what again? I already forgot. 6 something. What is it?
It's okay. You and me too. 638. We'll be there.
Yeah, stop by. Hopefully, if you're going to be in Boston, here is the big, for those of you who aren't familiar, it's the American Academy of Dental Sleep Medicine's annual meeting is in Boston starting on Friday, and we'll be there. Anything more about your company you want to talk about here, Ryan, before we get to some questions?
I want to be courteous of the folks that have stuck around. We've got plenty of people who stayed just over the hours. So, we can skip through this. I would just say, physically, if we don't get to it or not, this is something I want to be very clear about, guys. This is not something we do for anybody other than DS3 clients at the moment. We will physically, being that we have a $995 enrollment fee for our essentials package, that's, as you can see here, unlimited sleep testing referrals, unlimited diagnoses by the board certified sleep physicians. We're currently waiving that fee for all DS3 current users. So big opportunity we put together with you guys to make sure that your clients get the best of the best that's out there.
Well, thank you for doing that. I know we have a lot of our clients already have been using you, and they're nothing but positive,
Yeah, some great ones.
honestly, positive feedback. So, and from my office personally as well. And, if you're going to do dental sleep and you think, wow, I want to add some income to my practice, there's nothing you can do that can more dramatically increase the profitability of your practice than dental sleep, because the need is so high. Even if you only do a device every other month, and these are very reasonable projections. You're $2,500 a case, $350 lab, even if you're paying a third party to do your billing. And even if you pay for an annual subscription to DS3, you're still adding $7,800 at the end of a year just doing 6 devices. I mean, I was over in Orlando last weekend, Rich. You could probably take your kids to Disney for like a day for that, but it's kind of expensive, we found out. But do you do one a month? You're at 19,000. If you do one a week, you're pushing 6 figures, adding to your practice by getting involved in dental sleep. We're going to finish the questions in just a second, so we're going to open it up. A couple more announcements, and we'll do that. If you're not familiar with Dental Sleep Insider, go to this website, dentalsleepinsider.com. That is a digital magazine that's free, absolutely no cost. It just comes to your inbox, and it's just some really good information. You can even see all the back issues. One just came out this week. So dentalsleepinsider.com, sign up for the free magazine if you want. I promised that we would put these slides back up. Again, this is who we are. You can read our mission statement and what we do, but we help dentists succeed in dental sleep. And we're really the only true end-to-end solution for that. If you want to learn more about what we do, we're not pushy. We're very helpful. It will be worth your time to talk to Jody or Brandy or one of our other trainers, and they can just type in consultation, and we'll set up a free time to sit down with you, talk to you about your practice, talk to you about any dental sleep challenges you have, give you some good free information, and show you how our system can help you. So just type in consult if you're interested in that, and we will get back with you this week, likely tomorrow with that. We also do courses all over the country. We're adding to this all the time. Here's the current ones that we have. We do 1-day and 2-day courses. Just type in course if you want to secure $50 off for one of our future courses in 2017. $50 off for 1 day, and it's actually $200 off for a 2-day course. So there's the courses. I'll leave that up for a moment because I think I'll come back to that in a second and add June 27th. You'll be getting an email if you signed up for this one. That is our next webinar. Real excited. I know Doug fairly well. I've met with him. He's written some of the training manuals and so forth, DVDs for some of the CBCT machines, and he's going to talk to us not only about dental sleep, but how CBCTs help your dental practice, and then we'll hone in a little bit on the sleep aspects of that. So I'll leave that slide up, and we almost finished on time here. And if anybody needs any of those other slides up, let us know. And where are we at with the questions, everybody? Is there something we need to answer here? Rich, are you?
I'm chiming in on a couple of them. Ryan, you might want to talk about, there's a couple in here, and we've all been kind of sharing this responsibility, you guys, as we're doing that, because it's hard to type and talk at the same time. But Ryan, touch on the whole Medicare thing and the face-to-face, and how, as dentists, how do we